Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and I'm joined by our experts from MedStar Georgetown Cancer Institute to discuss everything you need to know about breast cancer. A new MedStar Health national survey found that 60% of women aged 40 and over are not following the recommendation from the American College of Radiology to have a yearly mammogram if they're at average risk. Since October is Breast Cancer Awareness Month, now is the perfect time to learn about those recommendations, the symptoms, screenings, staging, and treatment options for breast cancer. Before we get into our questions, let's meet our experts. First up, we have Dr. Miriam Jacobs. She's a board certified and fellowship trained in medical oncology at MedStar Georgetown Cancer Institute at MedStar Georgetown University Hospital. Next, we have Dr. Kelly Orwatt, a radiation oncologist at MedStar Health. She serves as medical director of the CyberKnife program at MedStar Franklin Square Medical Center and medical director of radiation oncology at the MedStar Health Bel Air Medical Campus. Dr. Jennifer Sun is a board certified general surgeon and fellowship trained breast surgeon. She serves as the site director for breast and plastics at MedStar Montgomery Medical Center. Dr. Michelle Townsend Day is the chief of breast imaging and chair of radiology at MedStar Union Memorial Hospital and MedStar Good Samaritan Hospital. And last but not least, we have Emily Kaczynski, who is a certified genetic counselor and our regional director of the genetic cancer program. Welcome to you all, and thank you so much for sharing your expertise with us today. Let's get into our questions. First up, how common is breast cancer and who is most at risk? And this is for Dr. Sun.
Hi, good afternoon, everyone. I'm Jennifer Sun. Thank you for the introduction. Breast cancer is fairly common in women. 1 in 8 women actually get diagnosed with breast cancer. Who is at risk? It's most commonly if you have usually if it's a family history, so if your mother, your sister, and a lot of the time, actually, it's not due to a family history at all. It's sometimes due to just luck, unfortunately. And so that's why it is important for early detection and to be able to examine yourself, to be able to advocate
No, I just
for
look
yourself
really
and
bad.
talk to your primary care
Well, I don't
doctors
like how I look.
about breast cancer screening. Signs and symptoms, usually there aren't any unless it's fairly advanced. So it's important, what I tell my patients is to always perform a self breast exam once a month, just so you know your body. If something ever feels abnormal to you, please don't hesitate to reach out to ask your primary care doctor or seek help. That's what we're here for, to answer any questions and to order any examination that you may need. Men do get breast cancer. It's usually 1% of men who get breast cancer. It usually happens in your 60s or 70s. A lot of the time, that's very common for genetic mutations, for example, BRCA mutations, but some men do get breast cancer without a family history. And so it's always important for men to know what's normal to them and what's not normal. Usually, if you feel any skin changes at the nipple or any masses, those are signs to get checked out.
How common, you mentioned it's not super common, but how common for men to get breast cancer?
1% of men. So essentially that translates to about maybe 260,000 diagnoses a year.
Okay. And did you mention the signs and symptoms of breast cancer?
Yes, usually there aren't any signs and symptoms. That's why the goal is for early detection. If you're having any symptoms, sometimes that can tell us a lot about our body, something new, always get it checked out. Sometimes it tells us that there's something else going on. But essentially, if you feel a lump or a mass that's very hard, like a pea size or even a golf ball, if you have nipple discharge, usually if it's bloody, those are some signs to seek help.
Okay. Is pain a symptom or a sign?
Usually, pain is not
Okay.
a symptom of breast cancer. Unfortunately, breast pain is fairly common in a lot of women, and that's because, one, hormonal fluctuations. A lot of time, women have cystic breasts, which are just pockets of fluid in the breast. That's fairly common to have, and they do not turn into breast cancer. But sometimes our diet can trigger these cysts to become symptomatic, such as breast pain. So caffeine intake, taking a lot of salt, for example, those are some things that can trigger breast pain.
Okay. Okay, that's great to know. Thank you. Dr. Day, at what age should I start getting mammograms and how often should I get them?
Um, so for screening mammography, the American College of Radiology recommends that all women get a risk assessment beginning by at least the age of 30, and that can be done by your primary care physician or provider. At that time, they'll risk stratify, meaning what's the risk of you developing breast cancer over your lifetime. If you're an average risk, you should start at the age of 40 and continue annually as long as you're in good health.
Okay, great. What is a 3D mammogram and how does it differ from the traditional 2D mammography?
So 3D mammography was developed or institute mainstream in 2011. And the difference between 3D mammography and 2D mammography is that 2D mammography is two-dimensional, whereas 3D mammography gives us a 3D rendering, or 3D picture of the breast. So we're looking at multiple slices through the breast, which gives us more resolution and enables breast radiologists to pick up more subtle findings.
Okay, that's great to know. And how do breast implants affect the accuracy of mammograms, or do they?
They don't. That would be the easy question. We do special views to make sure that we are imaging all the breast tissue that we can in patients who have breast implants.
Okay. What's the difference between a mammogram, ultrasound, and an MRI for breast cancer screening?
So a mammogram is the gold standard, and it's the test that we've known with multiple randomized controlled trials that decreases mortality from breast cancer over time. So that's our gold standard. Ultrasound is used in patients who have dense breasts because it's a more sensitive test in finding breast cancer in those patients who have denser breasts. Just an aside, when we speak about breast density, we're talking about the amount of tissue that your breast has. So breast tissue is made up of fat, which is black on mammogram, and breast tissue, which is white on mammograms. The challenging aspect of dense breast is the fact that while the glandular tissue is white, breast cancer is also white. So it can make it more challenging to find breast cancer in that setting. So ultrasound can help in that regard. And breast MRI is used for our patient population who has a greater than 20% lifetime risk of developing breast cancer over their lifetime. So there are three complementary imaging modalities, and depending on what your personal history is, use of breast ultrasound as well as breast MRI would be useful in order to optimize your cancer assessment.
Okay, that's great information. Thank you. Are there any lifestyle changes that can reduce my risk of breast cancer? And this is for Dr. Jacobs.
Yeah, so probably the biggest risk for women is for certain types of cancer is being overweight. So we recommend exercising, at least 30 minutes 5 times a week. And the other thing is alcohol. So even like 2 glasses of alcoholic beverage a week can increase your risk of breast cancer.
Oh, wow. Thank you. Shifting gears to genetic counseling, Emily, what percentage of breast cancer is genetic, and what is the process for genetic counseling and testing?
Yeah, so approximately 10% of breast cancer is inherited. So the majority is not. As we heard, the majority is caused by aging, environmental exposures, as well as lifestyle factors. If someone wants to learn more about if breast cancer could be inherited in their family, they could meet with a genetic counselor. A genetic counselor will analyze their medical and family history to determine the likelihood of having a genetic mutation. And a genetic counselor will also really talk about genetic testing, the benefits of it, as well as the limitations to see if it's a right choice for you. And if you decide to have genetic testing, it can be done through either a blood sample or a saliva sample. And then we typically get the results back in about 2 to 3 weeks. And the genetic counselor would go over the results, kind of reassess their risk for breast and other cancers, and then also develop a personalized medical management plan based on those cancer risks.
Okay. And who should consider genetic counseling for breast cancer?
Yeah, so red flags that we typically see in a genetic family include early age of breast cancer onset, so usually around age 50 or below. We also see a history of triple negative breast cancer as well as bilateral breast cancer. We typically see multiple generations affected with breast cancer and 3 or more cases on one side of the family. We can also see the presence of rare cancers, as you heard earlier, things like male breast cancer along with female breast cancer, as well as ovarian cancer or pancreatic cancer. Those are all highly suggestive of a possible genetic mutation.
Okay. And how can genetic counseling help a person understand the risk for breast cancer?
Yeah, so as we heard earlier, about women have about a 12% lifetime risk to develop breast cancer. If you have a family history, that risk may double or triple. However, if a genetic mutation is present, that lifetime risk for breast cancer could be 5 times or higher. So it can be scary to learn that you're high risk, but it actually can also be very empowering if you know your risk. There are steps that you can take, as you heard about some already. We typically recommend starting mammograms earlier. We also add in additional breast imaging like the breast MRI. And then some women will even consider preventative measures. So having their breasts removed, which reduces risk for breast cancer by over 90%.
Wow. What are the BRCA1 and BRCA2 genes? And I think you call them BRCA1 and BRCA2.
Yeah,
and how do they relate to breast cancer risk? Sorry.
Yeah, exactly. BRCA1 and BRCA2. So they're the most common cause of inherited breast cancer. They're also very high risk genes. So if you have a BRCA mutation, your lifetime risk for breast cancer is typically 60% or above. They also are related to other types of cancer, though. So it's kind of a misnomer that they're just breast cancer genes. So they also can increase risk for ovarian cancer as well as pancreatic cancer. And then we also see increased risk for prostate cancer in men who have BRCA mutations. So while BRCA mutations are definitely a large percentage of what causes inherited breast cancer, they're not the only answer. So there's actually over 10 other genes related to inherited breast cancer. Some of them are high-risk genes like the BRCA genes, but others are more moderate risk genes. So if you've had genetic testing more than a couple years ago, you may want to check with your healthcare provider if you need updated testing, because that previous testing may have only contained, BRCA and maybe a couple of those other breast cancer genes. So this current testing may be positive, even if that previous testing was negative, because the new testing has additional genes on it.
Oh, wow. That's great information. Yeah. A lot of times you only hear about the BRCA1 and BRCA2 and not about the others.
Yes, exactly.
So thank you for that.
Sure.
And thank you all for this important information. At this time, I'd like to pause and welcome our viewers again to our Facebook Live. Thanks to everyone for tuning in. We're here today to discuss everything you need to know about breast cancer in honor of Breast Cancer Awareness Month. I'm joined by our experts from MedStar Georgetown Cancer Institute, and we have more to talk about, so keep watching. Share this live stream with your friends. And if you have any questions, please share them with us in the comments, and we'll help answer those. So let's now talk about breast cancer diagnosis. Dr. Day, what should I do if I find a lump in my breast?
So if you find a lump on your breast, you go to your primary care physician or provider. They will write an order for you for a diagnostic mammogram, which is a problem-solving mammogram. You'll come to our suite. We would do a diagnostic mammogram depending on the age and ultrasound as well to determine what the cause of the lump is. Not all lumps are breast cancer, but all lumps do need to be evaluated thoroughly.
Okay, and what is a biopsy and why is it necessary for breast cancer diagnosis? Or I guess when is it necessary?
So depending on what the problem-solving mammogram shows in terms of what the diagnostic mammogram and or ultrasound shows, a biopsy is necessary to take tissue pieces from the breast to give to the pathology doctor to tell us what exactly is going on. We do that in a small number of cases if we can't definitively determine that the area of concern, whether seen on problem-solving mammogram or an initial screening mammogram, is not cancer.
Okay. And if I don't have any lumps or issues, but my mammogram comes back with positive findings, what happens next?
So not all findings that we see on mammography are cancer, and some of them may require short-term follow-up, which is typically a 6-month follow-up with either ultrasound or mammogram to make sure that they're stable over time. And when we say a 6-month follow-up, we mean that we're 98% sure that it's not a problem. So if we happen to be incorrect at 6 months, there would be no, it would not increase or increase the stage of cancer if present.
Okay. That's great information. Dr. Sun, are there different types of breast cancer?
Yes, there are certainly different types of breast cancer. It's either ductal cancer, which is the most common type of breast cancer, and then there are other types such as lobular cancer or even ductal carcinoma in situ. And all of them respond to different therapies, and so that's why it's important for us to get a diagnosis with a biopsy.
And are there different stages of breast cancer, and what do those different stages mean?
Yes, there are different stages of breast cancer. Stage 0 or in situ breast cancer usually means that the breast cancer is in the ducts. So it's called ductal carcinoma in situ. Then you have stage 1 through stage 4 breast cancer, and all of that depends on usually the size of the breast cancer. If it's less than 2 centimeters, for example, it's stage 1. If it's 2 to 5, usually it's stage 2. If it's begun to spread to the lymph nodes, then that's when we start calling it stage 4, especially if it's spread through other parts of the body, for example, liver, brain, and bones. But again, most commonly, because now we have mammography and early detection, usually it's early stages that it's diagnosed. And so early detection is key.
That's great. What are the main treatment options for breast cancer?
So there is local treatment for breast cancer, and then there is systemic treatment for breast cancer. The goal of local treatment means to get rid of the cancer at the breast and possibly the lymph nodes, and so that usually involves surgery. There are different types of surgeries that we can do nowadays. One is called a lumpectomy, also known as breast conservation surgery, or even a partial mastectomy. They all mean the same thing, and that means just removing the breast cancer and leaving the rest of the breast intact. And then obviously you have your other larger surgeries, such as a mastectomy, which means complete removal of the breast. And we also have reconstruction options at the same time with an implant or with your own tissue. That's just to name a few. We work closely with our plastic surgeons to make sure, one, we get rid of the breast cancer, but also to give you the most oncologically and cosmetically safe outcome that you can possibly have.
That's great. Is surgery a standard part of treatment?
Yes, surgery is definitely a standard part of treatment. And again, that's to remove it locally at the breast. And then you mentioned before other treatments. We have to make sure that breast cancer does not come back at the breast. And we call that local recurrence. And for those patients, if you choose to have a lumpectomy, that means we just get rid of the cancer, but leave the rest of the breast alone. We have to make sure it does not come back at that breast. And so radiation is recommended after that. If people choose to have a mastectomy, usually you do not need radiation. Usually there are certain times that you do, but that's your local treatment. We also have systemic treatment, and again, it's all dependent on tumor biology, and that can involve endocrine treatment, meaning stopping estrogen levels. And of course, there's your chemotherapy, but not all breast cancers require chemotherapy. So everything is individualized to the person's cancer biology and to the person, him or herself.
Okay. We hear a lot about minimally invasive surgical options. Are there those options for breast cancer?
Absolutely. So the minimally invasive cancer is, or surgery is usually a lumpectomy. That means just removing the breast cancer and leaving the rest of the breast alone. When they biopsy, when our radiologists biopsy the lesion, they usually leave a clip behind, and that's standard throughout because sometimes they do a really good job and they can remove the area, but the surgeon needs to find that. And so for a lumpectomy or partial mastectomy, I asked my radiologist to place a localizing device at the site of the cancer. And there are different ways of doing this. Here at MedStar, most commonly we use the seed. Other places use the wire or radioactive seeds. Again, it's institution dependent, but those allow us to find the cancer and just remove the cancer with a negative margin, meaning removing a little bit of extra tissue around to ensure that we remove all of the cancer.
Oh, okay. Are there side effects from surgical treatment?
Usually the side effects of surgery include soreness, pain, and recovery from surgery. A lumpectomy is usually an outpatient surgery. However, if you have a bigger surgery, such as a mastectomy with reconstruction, such as a deep flap, which is taking your tummy tissue and bringing it up to the breast, that is usually an inpatient surgery. But side effects most commonly are recovering from surgery, pain at the surgery site. If you do have a lot of lymph nodes removed at the time of surgery, you may have a risk of what's called lymphedema or swelling of the arm. And again, everyone is individualized, so we're happy to take care of you if you have those symptoms.
Okay. And you did mention this a little bit, but is breast reconstruction part of the treatment process?
Absolutely. So here at MedStar, we have a multidisciplinary approach for breast cancer. The surgeons or us, we work very closely with our plastic surgery colleagues where we can give you one, remove the cancer and make sure it's oncologically safe, you have a good outcome. But two, we work closely with them so that they can give you a good cosmetic outcome as well. Sometimes with the lumpectomy, some patients are candidate for what's called an oncoplastic surgery, where they can do a lift and a matching tissue rearrangement on the other side. If you have a mastectomy, you get to choose from an implant, for example, or autologous, meaning your own breast with your own tissue, such as your body fat, or what we call a deep flap, or even the back called a lat flap. But there are certainly other types of reconstruction that are that can be chosen.
Okay, shifting gears a little bit to medical oncology. Dr. Jacobs, as a medical oncologist, how do you treat breast cancer? And are there new treatments available?
Yeah, so we've had many new treatments over the past few years, but our treatment depends on the type of breast cancer that you have. So we look and see if the tumor is sensitive to estrogen or if the tumor is HER2 positive. And sometimes if the tumor doesn't have any of those markers, then we call that triple negative, and that's treated a different way. The majority of patients with breast cancer have something called ER positive or estrogen receptor positive disease, and they're mainly going on medications, which are pills that are blocking the estrogen levels in their body. Other women, if they have HER2 positive disease, then they're usually getting an infusion or a shot for that. And then triple negative breast cancer is usually still treated with a traditional chemotherapy, and now we use immunotherapy as well.
Okay. What are the benefits and potential side effects
So
I guess chemotherapy?
of chemotherapy. Um, so with usually we offer chemotherapy in women who have early stage cancer if we feel like that will reduce the risk of recurrence. So most of the drugs we're giving in the early setting are to reduce the recurrence rate of metastatic cancer. So common side effects are nausea. Some people have hair loss. Other things could be like, numbness or tingling in the hands or the feet. But we have very good supportive care regimens now. So most people are, able to continue working while they're getting their chemotherapy and do fairly well.
Are there benefits and or side effects for hormone therapy or targeted therapy?
Yeah, so for hormone therapy, the main benefit is it really reduces the risk of recurrence or developing metastatic disease significantly. The most common side effects that people complain about, because it does lower your estrogen levels, they're similar to like when women go through menopause. So a lot of people have joint aches, sometimes hot flashes, and fatigue.
Okay. And are there clinical trials available for breast cancer, and when should a patient consider them?
Yeah, so at our center, and other academic centers, we have many clinical trials for all stages of disease. And usually we encourage patients to consider clinical trials because it offers you another treatment that you wouldn't normally necessarily see. So it's just another option that you could potentially have. So we encourage patients to ask about clinical trials, and then usually we'll talk about clinical trials as well.
Thank you, Dr. Jacobs. Dr. Orwat, what is the role of radiation oncology in treating breast cancers?
So our role, somewhat similar to the surgeons, is local treatment, and it's to decrease the risk of having a recurrence in the breast or sometimes in the regional lymph nodes that the breast drains to. So after a lumpectomy, as you mentioned, almost always we're going to recommend a course of radiation targeting the breast itself. If you have lymph node involvement, we treat the draining lymph nodes as well. After mastectomy, there are times we still recommend radiation to decrease that risk. So if you have a positive lymph node, a large tumor, so over 5 centimeters, or if there is a positive surgical margin, then we add radiation in even after a mastectomy. And the magnitude of benefit, or how much you benefit from the treatment, ranges from about 50% in the non-invasive cancer, so like your DCIS, up to 2/3 in your invasive disease. And some studies show 3/4 risk reduction when lymph nodes are involved.
Oh, wow. Are there different types of radiation therapy available for breast cancers?
There are. So there's kind of the traditional whole breast radiation, which is usually done in what we call tangent fields. Sometimes when we're treating the left side, we have to do different things to protect the heart. So you could do a deep inspiration breath hold. You can treat patients lying on their stomach so that the breast falls away from the chest wall and the heart. There's also times where we can do partial breast radiation. So there are cases where you don't need to treat the entire breast. And so that gives the option to add things in like intraoperative radiation therapy, uh, brachytherapy, which is often done using what we call a savvy catheter or a mammocyte that sits in the lumpectomy cavity itself. And then radiation is delivered from the inside out, unlike typical radiation where it's from the outside in.
Okay, and you mentioned partial breast radiation. Who's an ideal candidate for that?
Yeah, so for partial breast radiation, you need to have what we consider very low risk breast cancer. So patients who are postmenopausal, usually. So sometimes it's 40 and up if you're very, very low risk otherwise, if not 50 and older, with a small tumor. So 3 centimeters or less is our cutoff. Lymph nodes have to be negative, surgical margins have to be negative. And if you meet all of these criteria and a few others, then we can talk about the possibility of partial breast.
Okay. And what are the side effects of radiation?
So with radiation, during treatment itself, the two things we see are tiredness and skin irritation. And the skin irritation is a lot like a sunburn. In terms of how significant they are, it varies considerably person to person. And we can't always predict how significant of a reaction you're going to have. But some women, they don't notice much in terms of tiredness and maybe get a little bit of dry skin and that's it. Other women get very tired. Some women have a really severe brisk reaction in the skin, so it gets very red and irritated. And sometimes we do still see peeling. It's not as often as it used to be. We have better techniques, better machines that we can decrease that skin dose to limit it somewhat. But under the breast, in that fold, and in the underarm, we do still see peeling sometimes.
Okay.
After the radiation's done, though, we do have to monitor for other side effects. The breast can change size a little bit, not dramatically, but a bit. Swelling of the arm can occur. It's not as common now that there aren't as many lymph node dissections, but we do still raise that risk a little bit. And then the late side effects that we really monitor for and that drives a lot of things we do on the treatment planning is protecting heart and lungs.
Thank you. Dr. Jacobs, can you tell us about cold cap therapy and who is eligible for it?
Yes, so cold capping basically is basically when the scalp is cooled with a special cap, and we use that for chemotherapy medications that typically damage the hair follicle and cause hair loss. So It depends on the texture of women's hair, so it doesn't work with all women. But it's something that we do recommend because it helps reduce the risk of permanent hair loss, which can be an issue with some of the chemotherapies that we give.
Great, thank you. And this is a question for all of you. If a patient has been diagnosed with breast cancer, should they get a second opinion? Did anyone want to chime in?
Chime in. You certainly can. You don't want to delay treatment too much, but there's usually time to get a second opinion and make sure that you are comfortable with your providers and with the treatment course being offered to you. Another reason some patients choose to get a second opinion is if they're interested in clinical trials. They may choose to go somewhere where those trials are offered.
And how can I support a loved one who has been diagnosed with breast cancer?
I think that all depends on the loved one, but obviously if they're your family members or if you're a dear friend, don't hesitate to ask questions like, how can I be there for you? Can I help you take you to your appointments? Usually if they require chemotherapy, for example, they have to be sitting in a chair. And so having them being there with them, I think you can bring someone to chat or to be with you in the chair. But again, everyone is different, and usually it's just resources that they need. So how attend support groups with them, which a lot of institutions have all of these resources for patients. And so we also have a wonderful social worker who's there to help give these resources to patients.
That's great. And why choose MedStar Health for breast cancer treatment?
I'll talk. We have a great team here. We all work together. So you're meeting most of us. So we have like our surgical team, radiation oncology team, radiologists, our genetic counselor, social workers. So we all work together, communicate closely, and we have cutting edge care here and really care about the patients.
We do have a question that did come in from our audience from Tracy. When breast cancer becomes metastatic, what exactly does that mean?
That means it's basically spread outside of the breast. So, either to the bone, liver, lung, brain. And at that point, we're looking at ways to kind of control the cancer, shrink it, quality of life.
Okay. Thank you.
Thank you.
For all of you, is there one thing that you would want our viewers to take away from today's broadcast? Can we start with Dr. Day?
The one thing I would like viewers to take away from today's broadcast is go get your annual screening mammogram. If you haven't already had a risk conversation with your primary care physician or provider, do that so that you can be empowered with your own healthcare. Screening mammogram saves lives.
That's great advice. Thank you. And Dr. Orwat?
I would say that breast cancer is very treatable and that we get new options and tools all the time. So, when you get a diagnosis, it's always very scary, but just remember, most people with breast cancer are ultimately cured. They do very well long term.
That's great. Emily?
Yeah, I think my take-home message would be just to try to learn as much about your family history as you can. As we talked about, it can make such a difference in what your risk is for breast cancer, especially if there is a genetic mutation in the family, and it can also increase risk for other cancers that may or may not be in your family. And don't forget to look at your dad's side of the family as well. A lot of people think that you can't, inherit breast cancer from your dad's side, and we get half our genes from our dad. So look at both sides of the family.
That's a great point. Thank you. And Dr. Jacobs?
Yeah, I think I echo Dr. Day's message, like to get your mammogram and then be your own advocate as well. If something doesn't seem right to you, don't be afraid to speak up, ask questions, go to your appointments. Yeah.
Thank you. And last but not least, Dr. Sun.
Don't be afraid to ask questions, to seek help. I know going to a doctor's office, no one really wants to go there, right? But we are here to help you. Like, I want to echo what everyone else said. Knowledge is power. Doing your own self-exams is power. You need to know what's different in your body that hasn't been there before. Getting your screening mammograms is powerful because you need to know what's happening in your body, knowing your family history, getting genetic testing, all of that. It's in our hands, and we can help you navigate the process. While it's new to you, if you do get a breast cancer diagnosis, it's not new to us. And so we know exactly how to help you all along the way. Be your own advocate. If you have questions, if someone's not listening to you, please speak up. We can certainly help you navigate that process as well.
That's really great advice. Thank you. Well, that wraps up our broadcast today. A huge thank you to all of our experts for spending time with us today and sharing this important information. And thanks to all of our viewers for tuning in and sharing your questions and comments with us. To learn more about our breast cancer services, please visit our website using the link in our comment section. Thank you so much and have a great day.